Hi everyone, my name's Joslyn Schipper. I'm a USF internal medicine resident, and today I'm going to be presenting on the rush exam. The title of my presentation is Rush Hour, the Use of Ultrasound in Undifferentiated Shock. So the objectives for this presentation, by the end of it, I hope you'll understand the role of ultrasound in the evaluation of shock. We'll review different frameworks for how to approach the rush exam, and you'll be able to recognize different POCUS findings in various types of shock, and we'll apply some evidence-based use of rush exam in clinical practice. So the main question, why are we using ultrasound for shock? Shock, especially undifferentiated shock, is a common presentation in both the ER and ICU settings, and it can often become a pretty big diagnostic challenge, as many patients can initially present similarly with hypotension, tachycardia, altered mental status, making figuring out the different causes of shock very difficult. In a setting where early diagnosis with proper treatment has been shown to decrease mortality. Usually we rely on labs and imaging as a crucial part of the workup of shock, but this can take time, which is where POCUS really comes into play as a helpful tool for rapid assessment of a patient's hemodynamic status. One of the protocols that is widely used in both the ER and ICU settings is something called the rush exam, which is what we'll be talking about today. It stands for rapid ultrasound for shock and hypotension, and it's used to rapidly identify life-threatening conditions in the setting of shock and hypotension. So there are four big categories of different types of shock we'll briefly go over. So the first one is hypovolemic shock. This can be caused to intravascular volume loss or hemorrhage. We'll really be focusing on the pump function or the cardiac output, and the IVC as a surrogate for central venous pressure. So as you can see in hypovolemic shock, we have a decreased cardiac output with a collapsible IVC indicating a low CVP. Next, we'll look at cardiogenic shock, which can be caused by arrhythmias, cardiomyopathy, valve failure. In this setting, you'll have a low cardiac output and usually a non-collapsible IVC, indicating a high CVP. In the setting of distributive shock, this can be caused by sepsis, anaphylaxis, different drugs or toxins, adrenal crisis. Usually we'll have an increased cardio output and a collapsible IVC. And the last, and probably the most useful for the rush exam, is obstructive shock, which is usually caused by tension pneumothorax, cardiac tamponade, pulmonary embolisms, which you can see a decreased cardiac output and a non-collapsible IVC. So some different frameworks that clinicians use to approach the rush exam. One is the HIMAP method, and it kind of systematically goes through the different views that you'll get when performing the rush exam. So first view you'll get is of the heart. You're really looking for cardiac contractility and ejection fraction, if there's a pericardial effusion that's causing tamponade, or evidence of RV strain in the setting of a pulmonary embolism. Next, you'll go assess the IVC, looking at its size and collapsibility, kind of assessing for a patient's volume status. You'll then assess Morrison's pouch or do a modified EFAST exam and assess for the presence of peritoneal free fluid. You'll then assess the aorta, looking at its size and assessing if there's evidence of an aortic dissection. And finally, you'll be assessing the lungs with the P representing a pneumothorax, and you'll be assessing, is there a tension pneumothorax that's causing this patient's shock? A different framework that people use is the pump, tank, and pipes, where pump is your heart. And again, you'll be looking for similar findings there. The tank is your IVC, looking at the size and collapsibility again. You'll be assessing lungs and Morrison's pouch, and then the pipes. Looking at your arteries like the aorta, or assessing if there's a DVT present, if there's a high level of suspicion for a PE. So how you'll approach this exam, you'll have your patient in supine position. Your probe choice, you'll be really using the phased array probe primarily, the curvilinear when needed, and a linear probe if assessing for a DVT. The first step is assessing the heart, that H and high map. So the primary goals for this exam, again, is assessing contractility, ejection fraction, looking for a pericardial effusion or tamponade, and assessing for right heart strain. The primary views that you'll get, really the parasternal long axis and the apical four-chamber will get you a lot of information. And then kind of going from there, based off what you're seeing, you can get the parasternal short axis or subxiphoid. So first, you're going to be really looking at the ejection fractioning assessment. Here we see 3 different examples of patients. On the leftmost, you can see that this patient has a hyperdynamic ejection fraction where the EF is estimated to be above 70%. You can see that the left ventricular walls changed more than about 90% between systole and diastole, and it actually appears like the ventricular walls are touching at the end of systole. This represents a hyperdynamic EF. This can be seen in the setting of hypovolemia, acute blood loss, and sepsis prior to any administration of vasopressors. These patients will usually benefit from some volume loading. In the middle, you can see an example of a normal ejection fraction. Here you can look at the anterior mitral valve leaflet assessing for EPSS, normal being less than 8 millimeters, or if there is evidence of heart failure, you would see it going up to more than 1 centimeter. On the right, you can see this is a patient with severely reduced ejection fraction. You can assess for fractional shortening and the myocardial thickening. As you can see here on the example on the right, this is very abnormal. Myocardial thickening is less than 30% in this patient, and the fractional shortening is less than 15%, indicating a severely reduced ejection fraction. Next thing you'll assess for is evidence for right ventricular strain. RV failure can be caused by a lot of different entities in medicine, but when it's acute in the setting of shock, the most likely diagnoses are a massive or submassive pulmonary embolism or right ventricular infarction. The RV chamber normally size should be about 2/3 the size of the LV chamber. If you notice an increase in this ratio or bowing of the interventricular septum towards the left side of the heart, this may be an indication that there's some RV strain. Here on the left, you can see something called McConnell's sign. So this occurs when there's coexistence of akinesia of the mid-free right ventricular wall with preserved apical contractility. So you can see at the apex where it's contracting vigorously compared to the rest of the right ventricle. On the right, you see something called D sign. So this is on the parasternal short axis view. You can see that the RV is dilated from increased pulmonary pressure, pulmonary artery pressures, causing bowing of the interventricular septum into the left side of the heart, which gives that left ventricle a appearance of the letter D, which is why it's appropriately called the D sign. Just as a note, the presence of any of these findings is suggestive of RV strain, but it's not specific to pulmonary embolism. If there's any evidence of right heart strain that you see on your scan of the heart, you should proceed to doing exam of the legs for a possible DVT. If you end up finding evidence of a DVT on your exam in the setting of right heart strain, the chances of the patient having a PE rise significantly. Next, we'll be looking to assess if the patient has evidence of a pericardial effusion or tamponade. So here you can see two different views of the heart. There are different signs that we look for to assess whether or not the patient has evidence of cardiac tamponade. So the first and earliest sign would be right atrial collapse, which is seen on the left side of the screen. On the right side of the screen, you see something called right ventricular diastolic collapse, and this is a later but more specific finding of cardiac tamponade. These findings can often be difficult to capture in real time when you're doing your ultrasound exam, so it can be helpful at times to freeze your image and scroll through the frame at a slower rate to determine when systole and diastole are occurring and see if you can find evidence of either the right atrial systolic collapse or RV diastolic collapse. More advanced ultrasound technique, you can get measurements of cardiac output. This you'll calculate the LVOT area. You'll also calculate VTI using these. You can use an equation and calculate your stroke volume and your cardiac output. These measurements are important as it can help you differentiate the different types of shock, especially when you combine it with other components of this exam, like the ejection fraction or when you assess the IVC. It can really help you narrow down your differential. So the next part of the exam, you'll be moving on to assessing the IVC. The primary goal of this exam is to assess the central venous pressure. Here's a table with the measurements that you'll be obtaining from this view. So first you'll be measuring the IVC diameter, and you'll also be assessing the percent of collapsibility of that IVC, especially during inspiration. So if it's less than 1.5 centimeters with more than 50% collapsibility, the estimated CVP is 0 to 5. On the other hand, if your IVC is very plump and the diameter is more than 2.5 centimeters, and it's not very collapsible and you see less than 50% collapsibility, the estimated CVP is between 16 to 20. And here we'll see some examples of IVC evaluations. So on the left-hand side, you can see a very dilated and non-collapsible IVC indicating a high CVP. On the right hand of the screen, you'll see a small and collapsible IVC indicating low CVP. You can perform this exam by in the longitudinal orientation and the subxiphoid area. You can place your probe just under the xiphoid and slide about 1 to 2 centimeters over to the patient's right-hand side, and you should be easily able to find the IVC. Again, you're going to be measuring both the diameter of the IVC and the response to patient inspiration during this exam. So the next thing you'll be evaluating in the rush exam is Morrison's pouch. You'll be doing really a modified EFAST exam. So you'll be scanning the right upper quadrant, left upper quadrant, and pelvis, really assessing for free fluid in the abdomen or thorax. These images usually performed in the setting of trauma, but are very helpful in a patient non-traumatic on the medicine floor who is hypotensive. It can really provide some clues to diagnoses like ectopic pregnancy, if they have massive ascites, if they have spontaneous intra-abdominal bleeding, a retroperitoneal bleed, or intraperitoneal rupture of AAA. So here you can see the different views that you'll get. Again, you'll be assessing Morrison's pouch and looking at the parasplenic space, also the pouch of Douglas in females, and the retrovesicular pouch in males. When performing this exam, especially in the upper quadrant views, you can tilt the probe towards the patient's chest to get an image of the diaphragm and the lung interface to assess whether or not there's evidence of fluid or blood in the hemithorax. Again, you'll probably see something called the spine sign if there's evidence of fluid in the lungs. The next part of the assessment is looking at the aorta. For this, you'll be evaluating if there's evidence of an abdominal aortic aneurysm or aortic dissection. You'll be looking at the aorta in the transverse orientation, looking at it at 4 different levels, just below the heart, suprarenal and infrarenal, and just before the iliac bifurcation. So first thing you'll be assessing for is a AAA. The normal size is around 2 centimeters. And here's some definitions of what an abdominal aortic aneurysm is. The diameter is greater than or equal to 3 centimeters, or if there's a 50% increase in the aortic diameter, and at the level of the iliac arteries, if that diameter is greater than or equal to 1.5 centimeters. Anytime in a patient that's presenting with hypotension and you see abdominal aortic diameter of greater than or equal to 5 centimeters, you assume that it's rupture until proven otherwise. And when doing these measurements, make sure for most accurate measurements, measure from the outer wall to outer wall. Here, on the right-hand side, we see an image of an abdominal aortic aneurysm with mural thrombus. Next thing you'll be evaluating for is evidence of aortic dissection. For this exam, ultrasound evaluation is specific, but it's not very sensitive. So if you have a high clinical suspicion of an aortic dissection and your ultrasound exam is negative, you should go ahead and proceed with a TEE or CT angiogram if the patient is stable. For this exam, you need to evaluate the abdominal aorta, the ascending aorta, and the aortic arch. And on ultrasound, you'll see evidence of the dissection flap, as you can see here on the ultrasound on the right hand of the screen. The next part of the rush exam is assessing the lungs. So here you're really evaluating for tension pneumothorax. Although this is far more likely in the trauma setting, tension pneumothorax can be cause of shock in medical patients as well, especially if the patient had a recent procedure like a central line or if they had a pacemaker placed recently, or if they recently underwent a thoracentesis. On this exam, you can also identify if there's evidence of pleural effusions or a hemothorax. So here on the left-hand side of the screen, you'll see normal lung sliding, and you'll see that ants on a log. In the middle of the screen, you don't see, you see the absence of lung sliding. Remember that the presence of lung sliding rules out a pneumothorax only at the specific point that you were scanning. So you have to make sure that you maximize your sensitivity of this exam by scanning multiple points on the chest. This exam can be easier sometimes if you perform it in M mode, and you'll see that seashore sign or the barcode sign, whether or not, depending if there is presence or absence of lung sliding. If you see the absence of lung sliding on your exam, just remember that it doesn't necessarily mean that there's a pneumothorax. There are many other causes of reduced or absent lung sliding in our patients. For example, if there's a large consolidation, or if there's an acute infectious or inflammatory process, different fibrotic lung diseases can cause absence of lung sliding. Even patients on ventilators and intubation can cause absence of lung sliding. Once when you see this on your patient, you should confirm the presence of a pneumothorax by looking for something called the lung point sign, which you can see on the right-hand side of the screen. This lung point is when you see the transition between the normal lung sliding and the absence of lung sliding. It's really that transition point between the collapsed lung and the normal lung. If you see this on your patient, you can definitively rule in a pneumothorax. It can also help you assess or kind of quantify how large your pneumothorax is. So sequencing of this exam, you'll start at the heart, you'll get your peristernal long view, and then your apical four-chamber view with your cardiac probe. You'll then proceed to the IVC with the same probe. You can switch to the curvilinear probe and scan Morrison's pouch with the splenorenal view and get those thorax images as well. And then you'll proceed to examine the bladder window. You can increase your depth at that point and find the aorta above and below the renal arteries with those 4 views that we had talked about, and then scan both sides of the chest for evidence of a pneumothorax. This exam, when practiced, it should take less than 5 minutes. You're really just trying to rule in and rule out different causes of shock in your patient. Some limitations of this exam: it's operator dependent, so make sure that you practice. Sometimes, depending on different patient factors, you can get poor acoustic windows, depending on body habitus, if your patient has COPD and they're emphysematous. And again, this is a screening tool. It does not replace definitive diagnostics with your labs and imaging, other imaging. Some confounders to remember that can distort your ultrasound findings in this exam will be if the patient is on a ventilator, that positive pressure ventilation can alter your venous return and your intrathoracic pressures. This ultimately will change your IVC diameter and collapsibility, making the IVC look more full and less collapsible, even if the patient is actually hypovolemic. So that's something to consider. Um, Likewise, if your patient has increased intra-abdominal pressures, either from ascites or obesity or abdominal compartment syndrome, this can artificially reduce the collapsibility or make the IVC appear small and mimic hypovolemia. Again, different types of arrhythmias like your AFib, um, can give you misleading impressions of your LV function or your preload responsiveness. So these are all different things in your patients that can distort your ultrasound findings and something you should take into consideration when scanning your patients. And again, as a reminder, if your suspicion remains high despite a negative ultrasound exam for a certain diagnosis, make sure you pursue further labs and imaging. So we talked a lot about the rush exam, but how good is ultrasound at really determining the type of shock that we see in our patients? So multiple systemic reviews and meta-analyses have shown that ultrasound is actually pretty good and fast and accurate at identifying different types of shock, especially obstructive. You can see here on the right-hand side of the screen a table of the different sensitivities and specificities found by Yoshida et al. In a 2023 article in Crit Care of the different types of shock and how good ultrasound was at making that definitive diagnosis. Again, there's some limitations, especially in your distributive and mixed shock. So in those scenarios, you should consider clinical context to put all the pieces together to make a diagnosis. But you can see here, especially with obstructive shock, it had a sensitivity of 82% and specificity of 98%. However, does this actually translate into improved clinical outcomes? So a study by Atkinson in 2018 did show that POCUS, the use of ultrasound, improved diagnostic accuracy in undifferentiated shock, uh, making that final diagnosis of 85% in the ultrasound group, and correctly identifying it in only 60% in patients where they did not use ultrasound. However, they did not find a difference in 30-day survival, fluid or vasopressor use, ICU or hospital length of stay, or CT scan utilization. So what can we take away from this study is that the use of ultrasound, it's an excellent diagnostic adjunct in our undifferentiated shock patients, and it can improve our speed and confidence of diagnosis. And the outcome benefit is not proven, but it likely depends on multiple other factors, like timely action on your POCUS findings. And maybe it's just a certain patient population that benefits most, like our patients with obstructive shock and evidence of tamponade. And again, operator skill and integration of your findings into your plan and resuscitation efforts likely contribute as well. So, quick summary of what we've talked about. We discussed the rush method and that high map framework to give us a structured and rapid approach to our patients with undifferentiated shock. This exam combines multi-organ views of your heart, your IVC, your abdomen, aorta, and lungs to kind of build a pattern and help you rule in, rule out different causes of shock in your patients. This is a screening tool to be used in adjunct to other labs and imaging, but it can help you guide early resuscitation measures in your patient. Again, these findings must be interpreted in the overall clinical context of your patient, and the use of ultrasound doesn't necessarily improve your, or it improves your diagnostic accuracy, but doesn't necessarily translate into improved survival in patients with undifferentiated shock, but can give you that reassurance on improving your differential for that patient. So here are my references. Again, thank you for listening to my presentation on the rush exam and use of ultrasound in undifferentiated shock. Thank you.